Good evening, everybody. Good evening. Good evening. Good evening. Good evening, everybody. Welcome to Ask Me Anything session of OMR subject. And we'll just wait for 1 more minute and then we'll start with your doubts that you all had submitted yesterday, today. Okay. Good evening. Good evening. How's your preparation is going on, guys? Just 1 more month left and then you all have your exam. How's your preparation going on? Final phase. Ayush sent some emojis. I don't know what that means. Yeah, yeah, we'll start with the doubts, okay? Good evening, good evening. Okay. Chalo, most of the people have joined. Yes, we can start the session now. Okay. I'm first going to take the questions that you guys had submitted in the Google form. Okay. All right. Chalo. So the first question, so what I had done is many students have given the similar type of questions. So I have just merged those and took one question for them. Okay, so many of you had submitted this question, important topics for medicine and radiology, or the most important topics that we need to study in this 1 month. Okay, so I'm going to give you the most important, must know topics, okay, from medicine and from radiology. Okay, so from medicine, the syndrome based question, very important, and this has got highest mark potential. Okay, you should know syndrome based or syndrome based clinical features or genes associated with different syndromes. Okay, then clinical based questions, or what they do is they combine clinical features, radiographic features, and histopath features together, and they give you the big clinical based question. Okay, so clinical based question on geographic tongue, leukoplakia, lichen planus, candidiasis, pemphigus, pemphigoid, OSMF, epulis, okay, or benign growths that you see in the oral cavity, hyperparathyroidism, the questions based on hyperparathyroidism, examiner's favorite questions. Okay, neuralgic pain, so clinical based question on neuralgias, paroxysmal, non paroxysmal, whatever we have studied. Okay, so these are must know topics of oral medicine. Next is must know topics for oral radiology. So you must know radiographic views and indications. Okay, radiographic views of let's say extraoral radiographs, TMJ radiography. Okay, then the skull radiography. Okay, the indications of it, and the name of that particular radiograph or the view. Okay, that you should know. Then developmental disturbances or different developmental tooth anomalies you should know. Okay, uh, normal landmarks that you see in IOPA, that you see in OPG. Okay, the most important landmarks, these two. Okay, that we will see later. Okay, one question you one of you have asked based on this. Then SLOB rule, very important. They will give you question based on SLOB. They'll not directly give you what is SLOB rule or what happens in SLOB rule, what we consider in SLOB rule. They will give you question based on this. Okay. Then radiographic faults or faulty radiographs, maxillary sinusitis, questions based on maxillary sinusitis, composition of developer fixer. These are direct questions. Okay, and then the very important that they ask in NEET as well as in INI CET. Okay, radiographic diagnosis. Okay, radiographic diagnosis, they will give you radiograph and about cyst, tumors, or any bone disease, or any systemic disease affecting the skull, okay, or the jaws. So these are must know topics that you should uh, go through in this 1 month, or you should know. All right. Moving on to the next question. Okay, similar question, but little much. I have put exact entities that you should know. Okay, so important radiographic image based questions. So you should know anatomical landmarks. Okay, you should be thorough with anatomical landmarks that you see in IOPA and OPG. Inflammatory diseases, the radiographic features that you see in osteomyelitis, and if they ask you rare questions, okay, osteomyelitis is common, okay, frequently asked, but if they take a question from the rare topic, so bronze. Okay, bronze is one of the rare topic. They can pick question from here. Or osteoradionecrosis. This is also commonly or frequently asked topic. All right. Next, cyst. So cyst, the radiographic feature or the interpretation of cyst, including radicular cyst. These are commonly asked cyst. Radicular cyst, globulomaxillary cyst, lateral periodontal, dentigerous, simple bone cyst, or traumatic bone cyst. Okay. Tumors, ameloblastoma, COT, odontoma, ameloblastic fibroma, ameloblastic fibroodontoma, AOT, odontogenic myxoma. Okay, coming on to bone diseases. You should know features of fibrous dysplasia, PCOD, FCOD, CGCG, ABC, aneurysmal bone cyst, cherubism, Paget's disease. Okay, and in skull manifestation, they'll just give you skull radiograph, uh, and they'll ask you which condition you see this changes, in which condition. So, related systemic diseases are multiple myeloma, hyperparathyroidism, Clausen syndrome, thalassemia, Sturge-Weber. So you should know the skull changes or skull manifestations that we see in all these systemic diseases. Okay. Now, other features or radiography features that you see in squamous cell carcinoma, that is malignancy, okay, or osteosarcoma. These are commonly asked questions. Okay. So these entities you should or you must know. Okay, there is no other option. These are basics. Okay, these are basics. If you don't know this, you have not studied radiology. Okay, so this was second question that somebody had asked. Now coming on to third question, how to differentiate radiographically between osteoblastoma, ossifying fibroma, and complex odontoma or complex odontoma. Okay, so here I have put the radiographs of all these three entities. First is osteoblastoma, second one is ossifying fibroma, and third one is complex odontoma. Okay, can you um, tell me what differentiating points you can see it over here? What differentiating point you can see it over here? Okay, first I'll explain, then you will understand it better. Okay, first we'll talk about osteoblastoma. Okay, so when we interpret any radiograph, you first check for the location of the lesion. Okay, then we check for the periphery, then internal structure, and then effects on the surrounding structures. Okay, now if we compare these 4 points, okay, osteoblastoma, more commonly it is seen or it involves spine. Okay, but it can also be found in tooth bearing areas, that is jaws. Okay, and TMJ region. Okay, now the radiographic appearance of osteoblastoma, you can see soft tissue capsule around the, okay, this. You can see the soft tissue capsule. Now here osteoblastoma involving the condylar region, correct? Now there is a radio opacity and surrounding it is a soft tissue capsule or radiolucent region. Okay, which depicts soft tissue capsule. Okay, so it means that this osteoblastoma matures. Okay, so in early stage osteoblastoma is completely radiolucent. It slowly matures, and at the end of or at the mature stage it becomes like this. Okay, and the outer layer or outer part of this osteoblastoma still remains as a soft tissue capsule, means it still needs to be matured. Okay, now periphery, you can see soft tissue capsule around the radio opacity. Okay, now internal structure, as I've told you, early stages you will see radiolucent lesion, and then as lesion matures, okay, it matures from the center. Okay, so center becomes radio opaque, then it matures centrifugally. Okay, that is why the outer layer remains radiolucent. Okay, then effects on surrounding structures. Now when the osteoblastoma develops in a particular region, let's say jaws, spine, or the TMJ region, okay, it can expand bone, but the thin cortex around the lesion is maintained. Thin cortex is maintained. It does not completely perforate the bone. Okay, so this is about osteoblastoma. If I talk about ossifying fibroma, okay, ossifying fibroma we have discussed in our classes. We had compared ossifying fibroma with fibrous dysplasia. Correct. Now, when we talk about ossifying fibroma, you can see the ossifying fibroma. The most common site is posterior mandible in premolar molar region. Okay. And the internal structure or the periphery of it is well defined. Well defined, as you can see it over here. Okay. Periphery is well defined. Internal structure is, again, this uh, again shows mixed radiolucent radio opaque stage. Okay, depending on how much calcification has occurred inside. Okay, so this shows mixed radiolucent radio opaque stage. Okay, it also depends on stage of maturation, how much calcified material is formed inside the lesion. Okay, stage of maturation. Now, effects on surrounding structures, okay, by ossifying fibroma. Now, as you can see, this ossifying fibroma, well defined, it is concentric, it shows concentric growth, and it expand in equal direction. Okay. Okay, so expansion of ossifying fibroma is equal in all the directions. This is concentric type of growth that ossifying fibroma shows. Okay. Now, okay. Talking about complex odontome. Complex odontome is very easy to recognize. Again, the common site is posterior mandible, first and second molar region. Okay. Uh, the outer or periphery of the odontoma is well defined. Okay, well defined. It is not ill defined. You can draw the margin of the odontome. Correct, well defined, but it is irregular, it is not smooth. Okay, irregular. Now, then the internal structure is completely radio opaque. Internal structure, as you can see, is completely radio opaque. Okay, completely radio opaque. And what are the effects on surrounding structure? So it can affect the eruption of normal tooth. Okay, so the complex odontome is related or associated with impacted tooth. Correct. So what it will do is it will restrict the eruption of normal tooth. All right. So these three entities, and there are these differentiating points that you need to remember over here. Okay. All right. Moving on to the next question. Okay, which one is more malignant, minor salivary gland or sublingual gland? This means that the tumor that affects the minor salivary gland and sublingual gland, the sublingual gland has highest percentage of malignancy, that is 80 to 90%. Okay, 80 to 90% um, chances that the tumor that is arising from the sublingual gland is malignant. Okay, so this is more prone for malignancy than the minor salivary gland. This is the direct question. Okay, the source, this direct statement is mentioned in Neville. Okay, and more sources are there. These direct statements are mentioned. Okay, now, okay, okay, all right. Next important question that I had taken is, please explain important points and differences between CT, MDCT, CBCT, and MRI. Okay, so let us first see differentiating points between CT, MDCT, CBCT. Okay, and I'll give you points for MRI also. So, CT is computed tomography. Okay, MDCT is advanced version of computed tomography. MD is multi-detector CT. Multi-detector. Okay, difference between CT and MDCT is what? CT scan machine have got single row of detectors. Single row of detectors. Okay, whereas MDCT have got multiple rows of detector. Okay, so what is the advantage of MDCT? The multiple slices are obtained simultaneously. Multiple slices are obtained simultaneously. That leads to the duration or scan time, short scan time, and the speed of this acquisition is very fast. Okay, speed with which the scan is taken is very fast in MDCT. Okay, so MDCT is an advanced version of CT scan. All right, now if we come on to the CBCT, we all know we have cone shaped beam. In CT-MDCT, we have fan shaped beam. So the area which is covered during the rotation, okay, around the patient is more in CBCT. Okay, we use flat panel detectors in CBCT. We had discussed this in CBCT. Okay, so during one rotation, it captures entire volume of the tissue. Okay, so the scan time is very short here, very short. Okay, and the speed is very fast. Okay, now the resolution, if we talk about resolution of CT, MDCT, and the CBCT, CT resolution of CT is a moderate. MDCT gives us high resolution and CBCT gives us very high. That is best resolution possible. Okay, so better than CT is MDCT and better than MDCT is CBCT. Okay, now coming on to the most important point here is soft tissue contrast. Soft tissue contrast. Okay, so soft tissue contrast that we see in CT is good. MDCT gives us excellent soft tissue contrast. Okay, CBCT gives us poor soft tissue contrast. Okay, but CBCT is best for hard tissue, best for hard tissue. Correct. Now radiation dose, CT scan high radiation dose, then MDCT variable or it can be high but same as CT scan only, and CBCT gives us low radiation dose. Okay, coming on to the next points about CT, MDCT, and CBCT. Artifacts that you get in CT, moderate artifacts, very less artifacts. MDCT lesser than CT. Okay, artifacts in MDCT that we get lesser than CT. Okay, but in CBCT we have more artifacts. So metal artifacts are mostly common. We had studied about CBCT artifacts, correct? So metal artifact that we get in CBCT more. 3D reconstruction using CT scan is possible. MDCT very nice, excellent 3D reconstruction we can get, and CBCT also gives us excellent 3D reconstruction. Okay, FOV, we had talked about FOV, which is field of view. Field of view, that is region of interest. Region of interest. So CT scan mein you don't have option. Okay, you just have to select the entire skull. So the FOV that you get in CT scan is large. MDCT also large, but in CBCT we get to select the FOV based on the region of interest. If you want single tooth, you can select the FOV according to that. If you want quadrant, you can select FOV according to it. Arch and then skull. Okay, so in CBCT we get to select different FOVs. Okay, according to region of interest. Talking about the cost of CT scan, high, MDCT very high, and CBCT as compared to CT MDCT is lower cost. Okay, so CT MDCT expensive. All right, now if I show you the pictures or the slices of CT and MDCT, this is CT slice. These are MDCT slices. Okay. So if you I've just put this slices to show you the soft tissue contrast that we get in CT scan. CT scan may, if you can see, you can just see the graininess. These are the soft tissues. Huh? This gray area, what you can see, these are soft tissues. Okay, so you can just see graininess. You cannot actually tell that it is a soft tissue, or you cannot clearly see the soft tissue in CT scan images. Okay, but if you see here in MDCT, you can see the soft tissue, the graininess, the noise, okay, that you get in MDCT is lesser as compared to CT scan. Okay, so that is why MDCT gives us excellent soft tissue contrast. Okay, excellent soft tissue contrast. If I talk about CBCT, these are CBCT images. 3D reconstruction that we talked about is this 3D reconstruction. You can get 3D reconstruction in CBCT. This is 3D image of the area which we have scanned. Okay, and here if we see CBCT slices, soft tissue, no soft tissue can be seen, just a gray area. Okay, no fine details of soft tissue, can see it in CBCT images. Okay, so these are differences between CT scan, MDCT, and the CBCT. Okay, now if I talk about the indications of all these three, which is very important for you guys. CT and MDCT can be used for soft tissue evaluation. But if they ask you for soft tissue contrast or soft tissue evaluation and they give you in option CT, MDCT, you can go for MDCT for best soft tissue contrast. Okay, it can be used for tumors, for trauma, for detecting any fracture, sinus pathology. Okay, CBCT is best for hard tissue. So any bone pathology or pathology involving teeth. Okay, it can also be used for implant planning, impacted tooth, for endodontic evaluation, for orthodontic evaluation, any impacted supernumerary tooth. You can go for CBCT. Okay, all right. Now, if I talk about MRI over here, MRI over here. Okay, MRI gives us zero radiation because it uses magnetic field. So, no radiation dose at all. No radiation dose used by MRI. Okay. If I talk about speed, speed is very slow. Okay. Speed is very slow. Okay. Scan time is long. Scan time is long. Okay. Then, if we talk about soft tissue contrast, best among all. Best among all. So I'll just write it down here. MRI gives us best soft tissue contrast. If you want to check bone in the MRI, no, you cannot see. You cannot see fine details of bone, and it is not at all indicated for hard tissue. Okay, so MRI gives us best soft tissue contrast or soft tissue imaging. Okay, if I talk about artifacts, MRI gives us motion artifacts. So since the scan time is very long, okay, patient needs to be in supine position for 30 to 45 minutes. Okay, we can get motion artifacts in MRI scans. Okay, if I talk about cost, very high, very high. Okay, so these are points for MRI. If I talk about the indications of MRI, TMJ disc, TMJ region, that too, disc displacement. If you are suspecting, you can go for MRI. You can go for MRI to view salivary gland tumors. Okay, any muscle or nerve involvement, you can get it checked using MRI. Okay, so these are indications for MRI. Okay, so I hope this is clear to you all. Moving on to the next question. Okay, explain all the important points related to maxillary sinus malignancy. Maxillary sinus malignancy. Okay, uh, just a second, guys. Okay, all right. Chalo. All important points related to maxillary sinus malignancy. Maxillary sinus malignancy. Okay. Now, we have studied in our class that when the malignancy arises from the mucosal lining of the sinus, okay, it all depends on which wall is involved. Which wall is involved. So, if I talk about maxillary sinus, okay, this is the sinus. These are orbits, and here we have maxillary teeth. Okay, so the signs and symptoms depends on which wall is involved in the malignancy. Okay, it all depends on which wall is involved. If the roof is involved, then all the signs and symptoms related to eye will be seen. If medial wall is involved, signs and symptoms related to nose will be seen. If lateral wall is involved, then signs and symptoms related to this region, that is vestibular region or maxillary teeth, will be affected. Okay. Then floor. If floor is involved, the palatal region will be affected and the symptoms related to maxillary teeth. So patient will have unexplained pain in the maxillary teeth. Okay. Sorry. So we have signs and symptoms depending on this. Most common symptom when there is a malignancy arising from the sinus, maxillary sinus, is facial pain and swelling, because here we have the sinus. Okay, when patient gives you history of pain and swelling in this region, okay, also nasal obstruction or swelling in the oral cavity, vestibular swelling, okay, you must give or you must keep malignancy arising from the sinus in the differential diagnosis. Okay, of course, you will not directly give the diagnosis as this, but you can consider this in the differential diagnosis. Okay, so when the medial wall is affected, which is in proximity to the nose, all the nasal signs and symptoms, that is, nasal obstruction, nasal discharge, bleeding from nose, or pain in this region. Okay, next, if the floor of maxillary sinus is affected, then what you can see is expansion of alveolar process, means palatal region. You can just palpate the palatal region or the vestibular region. You can feel the expansion. Okay, and unexplained pain, as I've told you, loose teeth. When you clinically check the mobility of maxillary teeth, you will feel that it is grade 2 or grade 1 mobile. All right. Then swelling of the palatal region. I have put the example when the floor of maxillary sinus is affected. I put the example, I put the pictures also later. Okay. When lateral wall is affected, again, facial swelling. Here you will see the swelling, vestibular swelling, pain and hyperalgesia of maxillary teeth. Okay. If roof is affected, signs and symptoms related to eye. That is proptosis and diplopia, double vision and outward bulging of eye from the socket. All right. Okay. So here I've put example. Just compare right side with the left side. Okay. Right side with the left side. Okay. Here you can clearly see the lining, the floor of maxillary sinus. Clearly see. Here you can see the lining, but it is discontinuous. Okay. It is discontinuous in this region. What what has happened over here on the left side? What has happened over here? Here also, if you can if you can see here, the lining, the floor of maxillary sinus is seen clearly. Here there is a discontinuity in the alveolar process or the bony lining. Correct? This is due to destruction of the floor of maxillary sinus. Floor of maxillary sinus. Here also there is destruction. Okay. If you see it clinically, you will see this vestibular swelling. Okay. The expansion of the alveolar process. Correct. Here also. Okay. If you clinically check this mobility of the teeth. Okay. It must be grade 1, grade 2 mobile. Okay. And when you check the sinus, if you compare the sinus in CT or CBCT, look at the right sinus, which is completely radiolucent, which is a normal finding of sinus. Left sinus completely destroyed. The walls are completely destroyed, and there is a opacification. Opacification that is happened in the sinus. Okay, so these are some signs and symptoms that you see in malignancy arising from the sinus. Okay, all right. Now, next question is how to differentiate PCOD, focal cementoosseous dysplasia, florid cementoosseous dysplasia, fibrous dysplasia, and Paget's disease radiographically. Okay, very easy to remember. Okay, I've put a table comparing all these entities. Now, again, we are going with the location. Okay, location of the entity, then whether it is single or multiple or diffuse, it involves the whole jaw. Okay, relation to the tooth, internal structure. Okay, border or the periphery of it. Okay, then effect on bone, effect on teeth, symmetry, and the unique feature that you need to remember for your exam. Okay, talking about periapical cementoosseous dysplasia, it is seen in anterior mandible, incisor region, mandibular incisor most commonly involved. Okay, uh, you can see multiple small lesions of it. Okay, not the single lesion. Periapical cementoosseous dysplasia, multiple small lesions. Okay, I will compare PCOD, focal, and the florid together. Okay, now talking about focal. Focal meaning only a focal area is involved. It will be apical to molar region most commonly. Okay, and the appearance, radiographic appearance will be same as a PCOD. Okay, but it will occur as a single lesion. In PCOD, we have multiple lesions localized in this mandibular anterior region. Okay, same. Florid cementoosseous dysplasia, it involves multiple quadrants. Multiple quadrants. Okay, and it is multiple and widespread. Now, relation to the teeth. PCOD seen periapical to vital teeth. Okay, focal. Focal is seen near tooth bearing, that is just apical to molar or premolar region. Okay, florid, you see it around multiple teeth. Okay, all these three entities follow same pattern. Okay, according to radiographic stage. Okay, first early stage is completely radiolucent, then mixed, then radio opaque, completely radio opaque. So all these three follows same pattern. Hmm? Border of the lesion is well defined and lobulated. All these three entities well defined and lobulated. Okay, internal structure according to stage can be mixed. Okay, It can be a dense radio-opaque mass at last stage, that is mature stage mein you will see dense radio-opaque mass. Okay. Now, effect on bone, no expansion, minimal expansion, and mild expansion possible. But mostly there is no expansion. You see it in PCOD, FCOD, and florid. Okay. Effect on teeth, no resorption. No resorption. Symmetry, localized. Okay. It is localized at particular site. Okay. This is bilaterally symmetrical, means multiple quadrants are affected. If right mandible is affected, left mandible will be affected in florid. Okay. All right. So this PCOD, focal and florid, differs according to site. Okay. And the appearance, internal structure, and the stages remains the same. Okay. If I show you the, yeah, okay. If I show you the image radiograph of this is PCOD. This is florid, FCOD. Okay. Can you see PCOD? The teeth are vital, no caries, no infection. At the periapical region, you will see the mixed stage. So, this is mixed stage of PCOD. The radio opaque mass surrounding the radiolucent area. Okay. This is PCOD affecting anterior mandible. Anterior mandible. Okay. If I talk about florid cementosseous dysplasia, can you see this quadrant affected at the apical region of the teeth? You can see well-defined radio-opaque masses, well-defined radio-opaque masses affecting multiple quadrants. Okay, this is florid. If I talk about focal, appearance will be same, but it will be seen just under one tooth or two tooth. Okay, just under molar or premolar. Okay, that is focal cementosseous dysplasia. The appearance remains the same. Okay, all right. Now, yeah, now we will talk about fibrous dysplasia and Paget's disease. Fibrous dysplasia, common location maxilla, unilateral, unilateral involvement. This is important differentiating point between fibrous and Paget's disease. Correct? Unilateral involvement. Paget's disease में you have diffuse involvement, that is bilateral. Bilaterally it is seen. Okay, the complete jaw, maxillary or mandible, okay, is affected. Paget's disease is a generalized skeletal condition where more than or multiple bones are affected simultaneously. It is not generalized, that is, all the bones are not affected, but multiple bones affected simultaneously. Okay, so we are concerned with the skull and the jaws here. Okay, now if we talk about the fibrous dysplasia, uh, the appearance that we get in fibrous dysplasia is ground glass appearance. Important points, differentiating point between these two. And here we get cotton wool radio-opaque appearance. The periphery or border of fibrous dysplasia ill-defined or blending border. Here we can see patchy sclerosis or patchy, poorly defined bony sclerosis. I'll show you the picture, you will get the clear idea of it. Okay. Now, bone. When we talk about effect on bone, bony expansion plus deformity is seen in fibrous dysplasia. In Paget's, there is bone enlargement. If the skull is affected, if jaw affected, then affected bone shows enlargement. Okay. Teeth displacement possible in fibrous dysplasia, and in Paget's, hypercementosis is the important feature. Okay. So if I show you the radiographic picture of it, this is fibrous dysplasia. Fibrous dysplasia. If I talk about the border of it, can you see this area? This area is normal bone. Okay, and this area is abnormal bone. Abnormal bone. Okay, this giving us which appearance? Ground glass appearance. And the borders are blending. You cannot uh, see the margin of it. Correct? The borders are blending. You cannot just differentiate just by looking at it. You cannot differentiate, yes, this is a different lesion. Okay, borders are blending over here. Okay, so this is about fibrous dysplasia. If I talk about Paget's disease, can you see the patchy bony sclerosis? Okay, what happens in Paget's disease? Basically, there is a abnormal resorption of bone by the osteoclast and a position of immature bone. Okay, immature bone. Okay, or that gives us this appearance. So this patchy sclerosis is due to abnormal bone deposition. Okay, and when it affects the skull, look at the appearance. Look at the appearance. Okay, so this is patch like sclerosis. Okay, all right, this gives us cotton wool appearance. Now, if we talk about unique features of this, PCOD, periapical to the vital teeth. Okay, this is solitary lesion, radio opaque. Okay, surrounded by radiolucency. Sometimes, if it is mature stage, then completely radio opacity, just apical to the any tooth. Okay, then FCOD maybe you can see cotton wool like appearance, but the masses that you see in FCOD, florid may you can see well defined radiopaque masses. Not in the case of Paget's disease. Paget's disease may you cannot see well defined radiopaque masses. You can see patchy, like ill defined, little ill defined, patchy radio opaque masses. Okay, of course, fibrous dysplasia में ground glass appearance तो है. All right. So these are differentiating points between PCOD, FCOD, fibrous dysplasia, and Paget's disease. I hope this is clear to you all. Okay. I hope this is clear to you all. Hmm. Okay. Is this clear, guys? Hmm. Important topics of radio I have explained at the start of the lecture only. Bhavishya. Copper bitten skull appearance. What? Srishti. Okay. MRI, how many Tesla? In dentistry, we use 1.5 to 3 Tesla in dentistry. Okay. Okay. Yes, ma'am. Okay. Chalo. Moving on to the next question. When Becquerel, Curie, Seward, Gray units used. Okay. We have studied this in dosimetry that I've told you to remember the SI unit of these quantities. Okay, and traditional unit sometimes if the examiner go for rarest question, then they can ask you traditional unit of it. Okay, so SI unit of exposure air karma, absorbed dose gray, equivalent dose and effective dose sievert, and radioactivity becquerel. Okay, so what it means, first of all, becquerel. Becquerel is SI unit for radioactivity. Okay, it actually measures the source strength. It actually measures the source strength. Okay, that means you have a radioactive atom, how much radiation that atom is releasing. Okay, is your that is measured in Becquerel units. Okay, all right. If whether it is used in dentistry, rarely it is used. Okay. Example, radioisotope. Okay. Gray unit. Gray unit measures the absorbed dose. Absorbed dose means how much dose this particular area of tissue is absorbed. Okay, how much dose this particular area of tissue has absorbed. Okay, so this gray unit is used for measuring absorbed, or this is unit for absorbed dose. Okay, sievert. Now sievert basically measures biological effect, means how much harmful your radiation is, how much harmful your radiation is to particular tissue. Okay, according to its radiosensitivity. All right, that is measured with the help of equivalent dose and effective dose, and these two quantities, the unit of these two quantities, sieverts. Okay, basically we use it for radiation safety and risk. Okay, how much harmful your radiation is, how much harmful that radiation is to particular tissue according to the tissue's radio sensitivity. Okay, so these three units, I hope this is clear. All right. Next, difference between, or different features between Carpenter-Krausen and Appert's syndrome. Okay, so basically these three syndromes that you guys have asked, basically it involves acrocephalopolysindactyly. Meaning what? It The Carpenter syndrome involves craniofacial anomalies plus limb defects. Limb defects is polydactyly and syndactyly. Polydactyly is extra digits, okay, presence of supernumerary digits. Syndactyly is webbed fingers, okay, means fusion of one or more digits. All right. So Carpenter syndrome mein you have both polydactyly and syndactyly. That is why the type is acrocephalopolysindactyly. Apert syndrome mein we only have syndactyly. Okay, that is fusion of the two or more digits. So that is why the name is acrocephalosyndactyly. All right. Craniosynostosis. Craniosynostosis, premature fusion of the sutures, is present in all the three syndromes. Okay, all the three syndromes. Syndactyly, again, this is present in Carpenter and Apert syndrome. Apert syndrome में this syndactyly, that is webbed fingers, these are called as mitten hands. These are called as mitten hands. Okay. This syndactyly, polydactyly absent in Krausen syndrome. Okay. That is why only the name is craniofacial dysostosis. Only craniofacial anomalies is seen in Krausen's. Okay. Carpenter may you have flat face with hypertelorism. Krausen's and Apert may you have mid-face hypoplasia and proptosis in Krausen's, the additional feature. Okay. Oral findings, high arched palate in Carpenter. Krausen's may crowding and high arch palate. Apert may you have shovel-shaped incisors and cleft palate. Okay. So if I show you the pictures of these syndrome, this is Carpenter syndrome. Carpenter syndrome. Okay, Carpenter may you have flat face with hypertelorism. All right. Krausen syndrome. Krausen syndrome may there is absence of polydactyly and syndactyly. No limb defects are involved in Krausen's, only craniofacial anomalies or defects. Okay, so we have proptosis. Proptosis, outward bulging of eye from the socket. Okay. Okay, and mid-face hypoplasia. Mid-face hypoplasia. All right. Moving on to Apert syndrome. Apert syndrome mein you have webbed finger, which is called as mitten hands. Okay, mitten hands, and we also have cleft palate. Cleft palate. If you see it over here, presence of cleft palate. All right. So please remember these points, important points that you have it in Carpenter, Krausen's and Apert. Okay, carpenter apart में you have limb defects. Carpenter में polydactyly, syndactyly both. Apart में you only have syndactyly. Okay, Crouzens में no limb defect, only craniofacial anomalies. Okay. Hmm. All right. चलो SLOB rule tube shift technique, how to use SLOB rule and solve the question. Okay, just remember SLOB rule में same direction lingual, opposite direction buccal. So now I have put two questions that you guys have to answer over here. Okay, SLOB rule. If your object is moving in the same direction as the tube shift, that means your object is located lingually. If your object is moving in the opposite direction of the tube shift, that means your object is located buccally. Okay, so I have put two questions. First, two radiographs are taken for supernumerary tooth. Tube is shifted distally. The image of object moves mesially. That is, the supernumerary tooth moves mesially. That means, where is this supernumerary tooth located? Can you guys tell me? Yes, opposite direction. So tube shifted distally, but the image moves mesially. That means it is located buccally. Correct. Very good. Now, second, in mandibular molar, the file inside one canal shifts in the same direction as the tube shift. Okay, file inside canal shifts in the same direction as the tube shift. What does this indicate? Which canal is that? Buccal or lingual? Is it buccal canal or is it lingual canal? Correct. It is a lingual canal. It is lingual canal. Okay, so they will not give you these questions based on SLOB directly. Okay, but they will give you such a kind of question that you need to solve. Okay, all right. Now, yeah, ray sum. Somebody had asked about ray sum. Okay, so ray sum, we use this term in CBCT. We use this term in CBCT. So ray sum, the term, okay, the term ray sum, meaning the theoretical definition of it is what? This detector of CBCT, detector of CBCT records the total attenuation along the path of X-ray beam. That is called as ray sum. Difficult? Okay. So detector records means when you pass X-ray, okay, through any tissue, this X-ray, the tissue has got hard tissue and soft tissues. Okay. So hard tissues will block or absorb the X-ray. Soft tissue will let X-rays pass through it. Correct? So the detector in CBCT machine, it detects total blocking of the X-ray beam. Okay, how much X-rays have been blocked by the hard tissue. Okay, and then it measures all the blocking and gives us final image. Okay, that is called as ray sum. And this image, it creates image that looks like OPG. This is the image that looks like OPG. Okay, this image is formed by adding many thin slices. This image is formed by adding many thin slices. Thin slices. Okay, thin slices. Now, these thin slices, you can see it here. See it here. And you can actually change the thickness between the slices. So, here I have shown you how much slice thickness we can change, how much lowest we can go for. Slice thickness means the distance between these two slices. Okay. Now I have selected 1.1. So the distance between these two slices is 1.1 mm. Okay. You can change it, or you can select the slice thickness up to 150 micrometer. Okay. So in RASUM, you can actually change the slice thickness and see or view your data. Okay. This is about RASUM. This is about RASUM. This is, I've tried to explain it in simple language. Okay. And I hope this is clear. Next, radiation physics. Somebody just had asked this radiation physics. So I'll tell you the important question that, important topics that you need to study from the radiation physics chapter. X-ray tube, the components of X-ray tube. Okay. Then the production of X-rays. Then the factors affecting X-ray production. Okay. Interaction of X-rays with matter. Okay. These all are important topics that you need to study from radiation physics. Okay. Radiation physics. That is all. Next, radiographic landmarks. Somebody had put radiographic landmarks. So I'll just tell you these two most commonly asked radiographic landmarks, IOPA landmarks. First, Y line of Anis, Y line of Anis, okay, which is crossover between anterior border of the maxillary sinus and the floor of nasal fossa. Okay, this you need to remember. Next is nutrient canal. Nutrient canal. This is also frequently asked. Nutrient canals. Uniform width of radiolucent bands that you see mostly in the lower anterior incisor region. Okay, these are nutrient canals which carries neurovascular bundles. Okay, all right. Chalo. Explain natural radiation versus medical radiation. Okay, now if I talk about natural radiation means, as a term suggests, natural, meaning radiation that we get naturally from the environment. Okay, so this involves cosmic rays from sun. Okay, the radiation from soil and rocks, this is called as terrestrial radiation. Okay, then we have internal radionuclide means the radio or radiation that we get from the ingested food. Okay, the food containing this uranium and the thorium. These also the sources of natural radiation. Okay, the medical radiation, these are man-made radiation. So radiation that we use it in healthcare units. Okay, these are medical radiation. It could be dental x-rays, it could be CT scan, it could be any skull radiography. Okay, so this medical radiation is given intentionally to the patient. Okay, for the benefit of the patient only. So these are difference between natural radiation and the medical radiation. Okay, and they have just given in the textbook, they have given annual effective dose that we get from the natural background, that is natural radiation also called as background radiation, and medical from healthcare units. Okay, so yeah, this is about this question. Okay, explain difference between contrast, density, um, how does it affects the image quality. Okay, now density, if I talk about density, uh, this degree of darkening or the opacity of exposed film, when you expose the film, okay, and when you process it, okay, when then you see how much dark or how much opaque that radiograph is, that is your radiographic density. Okay, it is measured using this logarithmic formula. It is measured using this logarithmic formula of optical density. Okay, and the curve or the graph that we put of exposure against this optical density, okay, this is called as characteristic curve, okay, or HND curve or Herter and Riffeldt curve. As you go on increasing the exposure, the density also increases. All right, the greatest diagnostic value, the density of your radiograph should be between zero point 0.6 to 3 optical density units. Okay, just remember this. Now if we talk about density, it is directly proportional to MA, KVP, and exposure time. So when you increase MA, KVP, and exposure time, your density will increase. Meaning your radiograph will be more darker. Okay. It is inversely proportional to focal spot and film distance. If you increase focal spot film distance, your density will decrease because it is inversely proportional. So the factors affecting density are these. Okay, if I talk about contrast, contrast is just a difference in densities. Okay, so we have discussed this high contrast radiograph, meaning you have very dark and very light areas on the radiograph. Okay, that is your high contrast image. If you have many shades of gray in the radiograph, it is low contrast image. Okay, and this contrast depends on KVP. When you increase KVP, when your KVP is more than 90, then you get low contrast image because these X-ray photons tries to penetrate through every tissue. Okay, and when you get this photons, the extra photons, extra X-ray photons, or you can get the scattered extra X-ray photons, your contrast will decrease. Okay, because you get many shades of gray in that case. Okay, when your KVP is low, that is between 65 to 70, you will get high contrast image. Okay. Now, if I talk about, yeah, so these, yeah, this is about density and the contrast. Okay. I hope this is clear. Then, yeah, values of radiographic exposure in patients and operator. So ICRP has given us dose limits, okay, for occupational. Occupational means the operator, okay, operator. Public meaning your normal layman, or you can say normal population. Okay, so operator में the people who work in the radiology department, for them the effective dose should be 20 millisievert per year. Okay, averaged over defined periods of 5 years. Okay, with maximum of 50 millisieverts in any 1 year. Okay, this you need just to remember. Okay, rectify this and you are good to go. For normal population, 1 millisievert in a year should be the effective dose. Okay, annual equivalent dose to eye, skin, hands and feet. Okay, just go through this. They uh, rarely ask this annual equivalent dose. Mostly they ask about effective dose. Okay, all right, moving on to, yeah, most important, I think 4 to 5 students have put this question: paranasal sinuses and different types of radiography use. Okay, I'm not going to go in detail about each and every radiographic view for paranasal sinus, but three important view and the indications of it. Okay, because questions are based on these three mostly. Okay, first is Caldwell. PA view. Okay, PA view. Caldwell view is modified PA view. Okay, you just modify, you just change the angulation of the X-ray beam. Okay, and here the Caldwell view is best for, I'm sorry, viewing frontal and ethmoidal sinus. You can see clearly frontal sinus, you can see ethmoidal sinuses, and the partial maxillary sinus, because since maxillary sinus is superimposed by this petrous regis. Okay, so partial maxillary sinus is also seen in Caldwell projection. Okay, next view is Waters view. PA Waters view में which uh, sinus is best seen? Maxillary sinus. So when you will be asked about which view gives us best view of maxillary sinus, your answer should be PA Waters view. Okay. Next is this. Now this is lateral skull view. Lateral skull view. Okay. This is not included like in the textbook. This is not included under radiography of paranasal sinuses, but this is the one view in which you can see all these sinuses very clearly, very clearly. You can see frontal sinus, you can see ethmoidal sinus, you can see maxillary sinus, you can see sphenoidal sinus also. Okay, so the best view that shows us every sinus will be your lateral skull view. Lateral skull view. Lateral skull view. Okay, the positioning of this patient has to touch the one side of the skull to the film, okay, or the cassette, and then the X-ray source or X-ray beam is positioned like this. Okay, so this gives us the best view for viewing all the paranasal sinuses. Okay, so this was one of the important question. Okay, now factors that affect the quality and the quantity of X-ray photons. We all know this, correct? Quantity of X-ray photon depends on MAS. MAS, correct? MAS, which is milliamperes and second. Okay, current and exposure time. The quality of X-ray photons depends on kVp, kilo voltage. Okay, so this is very easy, direct question. If you have MA in option, only MA in option, you can go for this option. If you have MAS in the options, you can go for MAS. Okay, all right. How long should we process the radiograph in developer and fixer? Okay, it depends. The manual processing of the film depends on the temperature. Okay, how much temperature your developer is. Okay, 68. If it is at 68 degree Fahrenheit, you can develop it for 5 minutes. 70, 4.5, 72, 4 minutes, 76, 3 minutes, and 80 degree Fahrenheit, 2.5 minutes. It all depends on how much temperature of the developer. Okay, then you fix it for 2 to 4 minutes. Fixing is same. Okay, fix it for 2 to 4 minutes, and then you can wash it for 10 minutes under the tap water. You can wash that film to remove all the residue of the developer and the fixer. Okay, all right. Yeah, this was the question that was put. How to join coaching for a full 1 year term? For this student, join our Telegram group. Just put your query over there. Our team will contact you and will tell you all the details regarding the plan. Okay. So, yeah. Now we will start with your doubts that you had put in the chat. Okay. I hope this is clear to you all. All the doubts, all the things that I've explained is clear to you all. Chalo, fatafat, I will go through your chat queries and then we can conclude the session, all right? Stephen Stephen Johnson syndrome. What doubt you have in that syndrome? We cannot we cannot discuss whole topic now, na? We have time constraint. So you can ask particular doubt in that particular topic. Zygomatic arch radiographic view, jug handle view. We all know this. Abhishek. Shweta, you can put your question again. Like you can write it down again. How to differentiate radiographically dentigerous cyst and ameloblastoma? So dentigerous cyst will be associated with the impacted tooth. Okay, pericoronal radiolucency. And in ameloblastoma, it is mostly multilocular radiolucency. Okay, the location of both is same, but the association of impacted tooth is with the dentigerous cyst. And in ameloblastoma, it is multilocular radiolucency. You can see the expansion, buccolingual expansion, evident buccolingual expansion in ameloblastoma. Okay, and in dentigers, you have pericoronal radiolucency. The radiolucency is attached to the CEJ. Okay, yeah. Mm, supernumerary tooth not associated with Gardner syndrome or Crouzon syndrome. Just a second. Hmm. Shweta, supernumerary teeth, multiple supernumerary impacted tooth associated with Gardner syndrome. Okay. Your question is, I think, exception. So your answer will be Crouzon syndrome. Crouzon syndrome, may you don't have the multiple impacted tooth. Okay. Paranasal sinuses, all the paranasal sinuses, as I have explained, lateral skull, maxillary sinus, waters, PA waters. Uh, Trigeminal, most common, yes, maxillary branch, yes, maxillary branch. Order of leukoplakia of occurrence. Leukoplakia में you have heterogeneous leukoplakia. Okay. First is erythroplakia, then heterogeneous leukoplakia, and then homogeneous leukoplakia. The malignancy, I think you are talking about. Malignant transformation. I think you are talking about that. Okay, big dreamy gull. Rotation of chin, what we see if placed lingual to focal trough, buccal to focal trough. Okay. Okay. So just remember when you rotate your head, rotate your head, okay, that means that side, if your head rotation is on the right side, that side will be minimized. That side will be minimized. Okay, that side will be minimized. And when you rotate your head, that side will be buccal to focal trough. Buccal to focal trough. Okay, that means your right side of the jaw is buccal to focal trough. Okay, when you rotate your head to right side. I think this is enough for big dreamy girl. Is this clear? Big dreamy girl. Is this clear? I think you're talking about OPG faults, correct? OPG faults. Bassett syndrome. Uh, Big dreamy girl. Is this clear so that I will. Hmm. Just a second, guys. I cannot see your questions. I need to join it again. Hmm. When chin rotates, if patient rotates their head during the acquisition or during taking the OPG, that time you get this fault in the image. That time you get fault in the image. So by looking at the image, you can say that the patient's head is rotated to right or left side. Okay. Bassett syndrome, uh, gene is affected, gene is involved. Bassett syndrome में I just Bassett syndrome में this this gene in apple core pattern enamel is not affected, just cementum and dentine. Uh, Apple core pattern. You are talking about radiation caries, I think. Yeah. So in radiation caries, you can see the caries affecting the cervical region. Cervical region. Okay. So not just enamel or dentine, some part of enamel might be affected because crown is also involved, correct? So crown has the outer layer of enamel, correct? So not only dentine and cementum, but some partial involvement of enamel could be there. Okay. Codman's triangle. Codman's triangle, you see it in osteosarcoma, which is a radiographic feature or bone reaction that you see in the osteosarcoma. Codman's triangle means your bone deposition is like this. This is this is seen in osteosarcoma. Okay, it appears like a triangle. This bone reaction is like a triangle, so we call it as a Codman's triangle. Easy. Okay, I think your doubts are. I hope your doubts are cleared. All the doubts are cleared. I hope all your doubts are cleared. Uh, if anything remaining, I think. Okay, what is angulation of canthomeatal line? Canthomeatal line should be at least 15 to 20 degree. 15 to 20 degree. Okay. Downwards, in the downward direction. Okay, 15 to 20 degree downwards. How to identify odontogenic keratocyst? Odontogenic keratocyst, what are the radiographic features? Scalloped margin. Okay, you can see root resorption in some cases. Scalloped margin, which is the important feature of OKC. Posterior mandible is involved. Correct? Mm. Okay, Beamsen. Okay, intrusion, root appear long or short. I did not understand this. Harshita, your question, make it more, I don't know, rephrase it or. Mm. All right. I hope this session was useful and you learned or many topics got revised. Yes, anteroposterior extension expansion is in the OKC. Yes. Yes, Sonia. All right, students. All the best for your exam last 1 month. Give it all, give it your 100%, and all the best to you all. Let me know your results and study well, eat well, sleep well, and we'll meet you in the next session, maybe in the recall session. Okay. Yes, more than sufficient, more than sufficient, more than sufficient. Be thorough with the notes and the cue banks, okay? And rest will follow, okay? 70 to 80% of portion is covered. The remaining, not 70, 80, 90%, remaining 10% they'll ask from the out or they ask outliers. So that we can, if you know that outliers, best. If you don't know, yeah, we can manage 10%. Okay. SWT, yes, if you have time, you can go through it. If you have enough time, you can go through it. Otherwise, just revise the topics again and again. Okay, revise topics, revise questions again and again. That is enough. Okay. Chalo, bye bye. Good night and see you soon.